So what do we do for this? So sympathy with joy intensifies the sum of the joy of the world, but sympathy with pain does not really diminish the amount of pain. That's so said Oscar Wilde in an essay he wrote. So what does this mean in practical? Is parental attention versus distraction. So what can we practically do if we don't have psychologists? Because, you know, I'm not a psychologist. I'm not trained in doing CBT. I don't have the time. But if you don't have readily access, what can we do in this situation apart from telling people to get back to school and get back to function and that? So, and we kind of work about distractions, and we're trying to help direct parental attention away from pain, and use of distractions is something that we can all do and may be helpful in taking the focus off and getting into the function. But easier said than done. So in paediatrics, we often talk about distractions, the importance of distractions, but what does it mean in reality, and what's the evidence for it? I've had heaps of parents over the years saying, distractions, you don't always talk about that, but it doesn't work. Actually, it does work, and there's been some nice studies showing that it works, but it does need to be taught. We can't just say to people, use some distractions, because what does that mean? And in my own injury, what I found is having people come around and visit me was really nice, but again, the best approach was getting back to work. When I was at work, I used to forget to take my paracetamol and Brufen, and the swelling and the pressure in my foot wasn't that noticeable, but in the weekends it was horrendous. So, yeah. So in that view, in writing this, I decided to look, are there any actual trials looking at distractions? Turns out there is. So it's based on social learning, so we kind of learn from others how to respond socially. And that pain is reinforced and maintained by significant others. And the authors of the study, Lynn Walker et al., and it's published in Pain 2006, they theorised that whilst parental attention with children's pain can be associated with more complaints, but they used parent training in both pain patients and control or well patients. They also theorised that their training will probably have a weaker impact on pain patients because they've had a long history of parental reinforcement. So, with that in mind, they recruited a whole bunch of abdominal pain patients, 110 of them, aged 8 to 16 from a tertiary paediatric gastro clinic. They had to have pain for more than 3 months, no organic illness. And when they broke the patients down, 60% were female, 93% were Caucasian. It's an American study. And the duration of pain ranged from 3 months to 11 years. So some of them were pretty intractable. And 95% the primary caregiver was their mother. And then they got a school sample of well children, 120 of those, similar age range, no chronic illness or disability, and they had to have less than 3 episodes of abdominal pain in the previous 2 weeks. Again, 95% were Caucasian. So what they did is they randomly assigned the pain patients and the well children to one of 3 groups. They either had parental attention or parental distraction, or the parents just got told nothing. And so what they did, and the parents and the children in either groups were not aware of the other conditions, the other training. So they just got told that we're going to do a physiology test on water loading. So the parents were actually trained on how to interact with their child after the water loading test. So it was both videos and short little vignettes, and they got taught these phrases. Some of them were, I know it, this is the attention group, I know it hurts now, but you'll be fine later. Or what does it feel like? I can imagine it must be really sore for you. That's what the parents are taught to say to the child who was in pain. The distraction group were taught, let's talk about something different. Or what do you want to do this evening? Or what do you want to do in the weekend? Or shall we get your friend around? So that type of thing. And in the no instruction group, the parent could do whatever they wanted to. So they had both videos and written examples, and they had to practice these phrases. And the assessors were also blinded to which training each parent had received. So the results of the study, with pretty simple video coaching, the parents learned these little vignettes, and they were pretty striking. And the next slide will show the actual graph of the pain. But basically, in the attention group, the children, the pain patients and the well children, doubled their symptom complaints compared to the distraction group. It was unbelievable. And the pain patients made much more complaints than the control group. And also the female patients, the girls, made much more complaints than the boys, and the female pain patients the most of all. So the thoughts were that sympathy and attention, it's a shared representation of experience and feelings. And if you get a lot of sympathy and attention, maybe children perceive the pain as being more threatening than it actually is. So in the no instruction group, some parents read a book, some parents made phone calls. It was done in the pre-social media era, so I presume nowadays most parents will be on Facebook or Instagram or whatever. But the trend for that group also was the parents to make more sympathetic statements to the girls compared to the boys. So the boys, they made more distracting statements, the girls, they made more sympathetic. So that was also things. The researchers also assessed how difficult was it for parents to learn and implement distraction strategies, and it was no more difficult for them to learn. But interestingly, the parents of the pain patients rated, because they were asked to then rate what they learned, how effective was it. So the parents of the pain patients rated the distraction strategies as having more negative impact on pain. So what that means is that distraction, the parents felt that the distraction would worsen the pain, whereas the opposite was true. And no parent of a pain patient rated attention as having any negative impact. That's probably... So that's the hard thing. So this is presumably due to parents saying that they feel they need to attend to their children's symptoms. So in that view, it's understandable. So it can be quite challenging to try and convince parents that reduction in attention is actually needed rather than more attention in the chronic pain situation. So this is a graphical representation of the number of the verbal complaints the children said for the attention group here versus the no versus the distraction. It's massive. I was really amazed at that. And also they assessed the children. They interviewed, and the children themselves said distractions make me feel better compared to those who receive positive attention. So the kids identified that. So, going on to another case, Sione. So this is a case of a patient of whom things were tricky and difficult. So it's not, it's always, I always like when I see the presentations, I like the stuff when things don't go well and are hard, rather than the stuff that everyone gets better. Because reality, you have these patients. He's a 7-year-old boy, had a really complicated past history. He was an ex-prem, so remember what I said about prems being sensitised. He had frequent respiratory tract infections in his younger years. And unfortunately, he got multifocal staph at 5 years of age, bad pneumonia, other staph, other places. And he unfortunately got a femoral line clot. He had a long stay in hospital, well over 6 months. It was a long time. He finally got discharged, but he was lost to follow-up. And the reason why he was lost to follow-up, multiple different DHBs in and out of Auckland, multiple different schools over the next 2 years. And over time, there was increasing swelling and pain of his right leg where he had the femoral line clot. After a long fight with ACC, on behalf of his mother, he was accepted as having a treatment injury. Now, I know that's the ACC terminology, but that terminology means kind of someone's to blame. The hospital was to blame. It's just one of those things that happen. He had been seen by an adult vascular surgeon in the private sector through ACC, who diagnosed him after doing some MRIs and venograms and that as having post-thrombotic syndrome. Now, I'd never really heard of that. I suppose you guys said maybe in adults, but it's basically where the femoral vein's still clotted and he had a whole lot of collaterals, but it was getting claudication, which, I've only did 1 year of adult stuff as a house officer, and I vaguely remember that, But unfortunately, like when you get ACC and new GPs and new paediatrician, no one, the ACC and the vascular surgeon didn't really communicate with his primary and secondary care team. And so basically Sione ended up presenting to Starship ED. He was in a wheelchair. His mother had rented a hospital bed. And he presented to ED because he was in severe pain. And it turns out he had no school for 12 months because of the pain. And then his mum decided to put him into a Maori immersion class, but he doesn't speak te reo. He was in increasing pain, he was off his feet, he was constipated, he was on a number of medications, and basically he was a very deconditioned, depressed little boy when I saw him in ED. Had some right leg swelling, but complained of constant 10 out of 10 pain, he had allodynia. So he clearly had central neural hypersensitization. He had a medical cause, he had claudication, but things had escalated hugely. On the ward, when his mum was around, he'd only use a wheelchair, but actually made some friends, and he actually could mobilise, get to the playroom, and he was kind of keen to go with his school with his ward friends who'd made. It was a really complex social history. They were really poor. There was isolation from the extended family. An older sibling had committed suicide. It was just horrendous. And he was actually largely illiterate. And we didn't know, was he illiterate because he hadn't been to school for, 12 months and multiple schools prior to that, or did he actually have intellectual disability? And there was a lot of parental anger over the treatment injury. This is, really summarised, but it was difficult. She wanted to sue the people who put the line in originally, and it was just terrible. I mean, this is New Zealand, you can't sue, but it was a really difficult situation. And a number of other practitioners thought, could this be Munchausen by proxy? Could this be, that this kid was kept at home and kept at school? And the parent could not accept chronic pain explanation. We later found a give a little page for vein surgery, even though the vascular surgeon said there was no benefit from that, and to look up the studies to show that. But there was a lot of blaming of ACC for taking so long, hospital for causing harm. There was a lot of team members that were sacked, and she kind of not refused to get him to the hospital school because of his perceived pain. And actually he kind of wanted to go there because his friends were going there, and she wanted to homeschool him in hospital. It was just... And they actually, in this situation, the best thing we could have done was phone the GP to find out what was going on in the background, which we got told everything. We had to bring ACC involvement, clearly needed codified cultural support. There was a lot of second opinions from the chronic pain specialist psychiatrists, huge amount of input from the psychologists and physios, and it ended up, we did do a report of concern to Oranga Tamariki. And that's really hard because from Oranga Tamariki's point of view, this parent is very involved and very engaged in that. But it really needed a lot of, close engagement with the local paediatrician, because it wasn't us, they were a different DHB. ACC, the GP, Oranga Tamariki, codifying the school. And it was a really difficult case, and this is really a correct summary, because this was a really challenging family under significant stress. The kid had real cause for ongoing pain, but how to manage that. And there was adoption of the sick role by both the child and the parent. And I think for this situation, the child was just doing what the parent wanted them to do. And there was a lot of anger, and I find when there's anger, I find that really hard to deal with in terms of, you've kind of got to accept it and move on. It happened. It was unfortunate. It's no one's fault. But if they don't kind of get over that, that's really hard. And I think the big thing, what we learned about this was coordination. So there was a really tight partnership between primary and secondary care. Whenever this kid rocked up to his GP, they only saw one of two people. And also ACC as well. And Oranga Tamariki, if needed at times, with appropriate cultural support. So what was kind of done was there was quite tightly team goals. We wanted to keep him in school. That was non-negotiable. We just did not want to do homeschooling at all. Some graded exercise with physio support. So we just kept the goals really tight. There was team consistency. She wasn't not allowed to sack anyone. Regular group appointments, this is easier said than done, but it was just easier to meet everyone all together. And ACC, and if the wheels fell off, there was always the bringing Oranga Tamariki back involved. So these sort of cases, thankfully only a really small number, we have them. I think we always really emphasise teamwork and beware of team splitting. So, the old stories, you kind of thought I was fantastic because I'd found all this stuff from ACC and the private sector, but then I got sacked after a few times because I made him get up and go to school and stuff. The input from primary care was really vital. So they couldn't go to multiple different doctors and get different site. We don't say different opinions, but we all phrase things slightly differently, and people were really good at focusing on that. The focus on those 4 S's and really clear goals. So we actually had a contract that this is what the parent had to agree. The pain education was vital, ongoing emphasis, regular clinic follow-up, and sometimes we do think about child protection. So but that's really hard because from Oranga Tamariki's point of view, these are really caring parents who are really involved and engaged. So last sort of case, we'll just skip through this one. This is a headache of a 13-year-old depressed girl. So what do? Try and identify these guys early. History and exam, careful investigation, focus on the 4S approach, plus minus medication. How to try and coach parents to not give too much attention, use of distractions. And I find regular follow-ups really good in terms of trying to keep things progressing forward. I use lots of resources. I don't know if Kids Health have a fantastic chronic or persistent pain things, and they have lots of links to all these things I've written down there. So if you go to the Kids Health, and at the bottom is a really lovely understanding pain video. I really like it, but it is a bit focused on the brain as the cause of the pain, which we all know, but sometimes I've had some parents perceive it as it's all in my head. And the Starship guidelines as well. And these are I've taken some screenshots of that, so I can give you the links. But it's all much the same thing, so. And overall prognosis, do these guys become big painers? I think a couple of people have had big painers a lot who were little painers previously. And I think the fact is lots of utilisation. So seeing you guys, ED, us, if they have lots of other symptoms, somatisation, if they catastrophise like I did with my ankle, hesitancy to do any exercise, and if the kids involved in the pain things. And so I'll skip through this, but do they become big painers? About 41% of abdo pain have ongoing issues as adults with functional, and if they're depressed, they've got depressive symptoms, that's a big red flag for that being maintained, or somatic symptoms or other GI symptoms. Another study, 15 years later, 155 children with recurrent abdominal pain, and about 35% had ongoing pain. So now what? Again, early identification, 4S functional approach, reduce pain attention, focus on those with depression, anxiety or somatisation. They're the more likely to go on as adults.